you're missing a category. So who wants to be on the drinking team? See, you got lots of volunteers. Okay, so I didn't want to put together a PowerPoint presentation. I heard you guys had a bunch of them. I thought we'd just make this interactive. And I thought we'd concentrate on some of the things that you may not know that you really should know. So, what percentage of people that have a heart attack have symptoms before the heart attack? You guys know this?
Most.
Hmm?
Most people.
50%. Why? Why do only 50% of people have angina before they have a heart attack? So, people have plaques in their arteries, and this may be a 20% plaque. And how much plaque do you need to cause angina? You need a 70% plaque to cause angina. Okay? So this patient has a 20% plaque. What happens is that there's cholesterol in the plaque, and this coating, the skin, breaks open, and the cholesterol underneath is exposed, and then you get a big blood clot. That's what causes a heart attack. So 75% of people that have heart attacks have lesions which are less than 50% in diameter. So most people will not have angina before their heart attack. Does that make sense to you? Okay. So it doesn't mean that patients that come in with a new onset chest pain don't have coronary disease. Now, how many of you have been involved in the care of people who have had heart attacks? Okay, so this is a relevant topic we're going to talk about. How many of you actually know how we prognosticate? Every day in the CCU, there's 5 or 10 new heart attacks coming through. How do we decide what the patient's prognosis is? Give me, help me.
Comorbidities, the troponin rise, what their ECG looks like. Is that what you're looking for?
Yeah, those things are important. So the cardiologists do something automatically in the first 2 days, and they apply the Killip class. This is really simple, but it's important. What's the Killip class?
Prognosticator.
It's a prognosticator. So if you have a normal blood pressure and you have no CHF in the first 48 hours, that's Killip 1. And the mortality at 30 days is 2%. Okay? If Killip 2 is if you have crackles less than 50% of the way. So crackles, less than 50% on the way up. So you guys all listen to the chest, right? If you guys have a little bit of heart failure, mortality jumps to 10%. If we hear an S3, that's 2A, 2B is where you have an S3. We hear an S3, your mortality is 15%. 3 is you have crackles greater than 50%, so you're in pulmonary edema, your mortality is 40%. And if you have a low blood pressure, your blood pressure is less than 100, you are in shock. So 4, shock, mortality 60 to 80%. Do you think most of you can actually figure this stuff out?
Yeah.
Do you think this is prognostically important?
Yeah.
Have you guys ever done this?
No.
I don't see why not. I think this is within your scope of work, and to know which patients are going to do well and which patients aren't going to do well. Now, some of the stuff we heard from Leah was very important. So the higher your troponin, the more likely you are to have a poor heart, and the more likely you are to have a bad outcome. The older you are, the more likely you are to die from a heart attack. But This is what we do in the first couple of days.
So Ken, with the, say if you're still at class 2, is that for immediate prognostication or like long-term prognostication? Or
So this is in the first few days. And then we go on and we fix the patients. Usually we give them thrombolysis, or we open them up. And then at the end, before they go home, we reprognosticate. So when we reprognosticate, and we do this, like doctors do this with every single patient, and every medical resident I've ever taught, they don't know this until they finish the rotation. But it's so simple, you guys should be doing it. So there's 3 circles that tell you how the patient's going to do. These 3 circles are to do only with the heart. Okay? So you understand that a 90-year-old guy that has a heart attack is going to do worse than a 60-year-old just because they've got poor organs all over the place. But when you talk about the 3 things to do with the heart, what's the most important prognosticator? Come on, echo people.
Yeah.
Ejection fraction. So how well does the heart pump? If you have a big heart attack, you don't live long. If you have a small heart attack, you live a long time. So this is the most important curve in all of cardiology. Here's the ejection fraction of 20, 40, and here's 60%. So this is mortality. What's the normal ejection fraction?
60.
So ejection fraction is the percentage of the blood that gets pumped out of the heart with each beat. And normally it's about 65%. Okay? So does anyone want to draw this curve for me? Nobody?
I think you volunteered
Like
to
this?
go and draw it.
I don't.
Yeah.
Here's a brilliant research nurse.
Shouldn't you be on the research team?
Yeah, oh,
I
Naomi.
have other skills.
Yeah.
Okay. You guys agree?
Yeah.
This is wrong.
Sorry, I was thinking, that's my Japanese thinking.
So, if your ejection fraction is above 40 or above, your mortality is really low. If your ejection fraction falls below 40, your mortality rises exponentially. How many of you have seen an ejection fraction on your patients? All of you. How many of you actually thought about what it means to the patient? You know, this is the thing that really gets me, is I know it's busy, but you guys should have an idea of whether these patients are going to go out and do well or not do well. So, and if the ejection fraction is above 40, your mortality is low. Okay? Once it goes below 40, mortality rises exponentially. And I tell people, it's like you start off with your car is an 8-cylinder engine. Well, you're going to live a long time if your 8 cylinders work. If you had a small to moderate sized infarct, your ejection fraction is 40, I tell them you've got a 6-cylinder engine, so you've got less reserve, but you can live on a 6-cylinder engine. If you're down here, then you're working on a 4-cylinder engine, and you even lose another cylinder, you can't get up the hill anymore. So this concept, I think, is really important for cardiologists. Okay?
It can change over time.
Oh yeah, but so we do an echo or we do a ventriculogram before they leave hospital, and we get an ejection fraction. Now that's not the be-all and end-all. So we can talk about that. So here's your heart. Okay. Here's the left anterior descending artery supplying this wall. This artery is blocked. This stops moving. Okay, so this part's not moving. Okay. Well, what happens acutely? Well, this part is stunned. It's like I punched you, And some of it's going to wake up a little bit later. So this wall, although it's akinetic now, it's not moving, some of it may improve in 1 month's time. But this part, what happens to this wall? So when you have a heart attack, your body releases adrenaline. This part of the heart stops moving. Your heart makes more adrenaline to make the heart beat harder. So if this wall is not ischemic, so there's no problems with the blood flow, this wall becomes stronger. So your ejection fraction looks better than it actually is for the first 2 weeks. So in a month's time, this wall will get better. This wall will settle down. It will not be hyperdynamic anymore. And your ejection fraction will change. The average improvement in ejection fraction by day 30 is about 5%. Okay. But the thing that's important is really, you guys should know what this means. And if someone has an ejection fraction of 20%, their mortality is way up here. If their ejection fraction is 50, they have a low mortality. Okay? What's number 2 in terms of most important for predictors of outcome?
Rise in their troponins? Like the peak of their troponins?
Well, the troponin peak correlates somewhat to your ejection fraction. And if you have a troponin of more than 30, the chances that you've had a big heart attack are increased. But the troponin doesn't correlate really well with ejection fraction. But the second most important thing is the amount of ischemia you still have. So you take a look at this patient's arteries, and they've got some narrowings in here, okay? And let's say I can't fix them. So if you have ischemia, then this patient's at risk of future heart attacks. And if I can't fix that, the patient's prognosis is really bad. So how many of you have seen the angiogram on your patients? Yes, you all have. And guess what? A lot of your patients, they have one narrowing. It was blocked and now it's stented. The other arteries are okay. That patient does not have any ischemia. That patient is low risk. But if the patient has triple vessel disease, is inoperable, that patient is extremely high risk. Okay? So that's the second most important thing. And that's why if patients have ongoing chest pain after their heart attack, we get really worried because that's a sign they've got ongoing ischemia. Okay? And the last thing is whether they've had VT or not. So if you have lots and lots of PVCs and non-sustained VT, this is another marker that increased risk of dying from a heart rhythm problem. Okay? Those 3 things are what determine your prognosis. Do you think you guys can adopt this in your clinical practice?
Yes.
I think you can. I hope you guys are interested enough to try to apply this. Now, it turns out that what percentage of people have a low-risk heart attack? Roughly 75% are at low risk. And they can go back to work within a few days and have a good life. About 15% of people will be at moderate risk, and about 10% of people will be at very high risk. So, who's at high risk? Yeah, well, if you have an ejection fraction of 20%, you're in congestive heart failure at the time you go home. You can't walk very far because you're short of breath. You're having ongoing arrhythmias. Those people are at very high risk. So these group are people that may have a low ejection fraction, 30%, but they're even not in heart failure. These guys are at high risk of going into heart failure when they leave the hospital. So this group, you got to watch carefully. This group, you say, you had a small heart attack, your prognosis is still very good, go and have a good life. Okay, now, your patient had an inferior infarct. And the inferior infarct is caused by the right coronary artery. It's just like this. So the right coronary comes off here and supplies the inferior wall. So if you block down here, you get an inferior part. Now, I fix this. We fix this in the cath lab, and the other arteries are good. Okay, so the patient's got a stent here. Does the patient need to take medication, or are they fixed?
They need medicine.
They need medication.
Why?
Keep that stent open.
Prevention.
To prevent further MIs and.
Prevent remodeling.
So you have no idea of what percentage of patients want to stop their medications after they've had their heart attack. They all want to stop. And this is where you guys are really important, because you have to explain to them why they cannot stop. And, but I wonder if you can explain that. So, their arteries are all fine. Why would they need to take medication?
Prevent remodeling, prevent restenosis,
Prevent plaque
all
buildup.
that.
So, I start out by saying that 75% of heart attacks are caused by narrowings, which are less than 50% in diameter. Okay? So this person here, he's still got these 20% narrowings here. Okay? So it's these ones that are actually going to cause the heart attack. Okay, let's say I have somebody who's got stable angina. Okay, and I said a 70% narrowing cause angina. This patient has 80%. This is someone who's never had a heart attack, stable angina. He has chest pain when he walks, goes away when he rests. He comes to the cath lab, 80%, 20%. Which artery is the interventionalist going to fix? It's going to fix this one. Okay. Which artery is it that causes the heart attack? These ones. Okay. So this one is an old narrowing. Old narrowings grow slowly, and this one has a thick coating on it. So it's called a thick fibrous cap. These ones are young. They've got a thin lining. And thin linings are more easily ruptured. So again, these are the ones that cause most of the heart attacks. And the interventional cardiologist is only going to fix this one. So what can treat these ones? Medications. So I went to a talk, and it was one of the best talks I ever heard. It was given by an interventional cardiologist. And he said, when I put a stent in, I'm treating 3 centimeters out of 5 kilometers of blood vessels. You have 5 kilometers of blood vessels in you. So, you know, there's no way putting a stent here is going to prevent a heart attack here or prevent a stroke. But if you're on aspirin, it works throughout the entire body. So, you must make people understand that just because they had a stent in and their arteries look good, it's not. They have to take medications. And how long do they have to take medications for? Life. So, coronary disease is a lifelong disease. So aspirin reduces the risk of heart attack by 25%. Okay. There are very few drugs in medicine that reduce the risk by more than 25%. So everyone you know has a heart attack has to go on aspirin. What else do they go on?
Yeah.
Well, historically, the second drug we added was a beta blocker. Okay. They reduced the risk by 25%. Then the next drug we added was a statin. And this one is actually probably a 30% reduction. But, you know, 25 is close enough. And what's the last drug we give? ACE. That's 25%. So that's 105% risk reduction. So if you take these, you will live forever? Is that the way it works? No, how does it work? Okay, so this is the way it works. You had a relatively small heart attack, an average sized heart attack. your ejection fraction is 45, you've been fixed. What's your risk of dying from a heart attack these days?
It's low,
Give me a number.
no idea.
10%.
It's about 6 to 8%.
Close.
Yeah, so in the 1950s, mortality from a heart attack was about 40%. They used to keep you in bed for 3 weeks, and you got DVTs and pulmonary embolism. But nowadays, patients are out in a hospital within 48 hours. So the mortality is low these days. But if you survive your heart attack, the risk of a heart attack or dying in the next year is roughly 8%. So it's 8%. You give them aspirin. That's a 25% reduction. You're down to 6%. 8 to 6. Now you're starting at 6%. You're adding a beta blocker. 25%. You're down to 4.5%. Now you start off at 4.5 because you're on background therapy already. You give them a statin. You're down to 3%. Now you're starting at 3%. You give them an ACE inhibitor. Another 25% reduction. You're down to 2.3%. So is it worth it for your patient to take all 4 medications to get down from a risk of 8% per year down to 2.3%? So, you guys have lots of patient contact. The physicians only have a little bit of patient contact. You guys must emphasize this.
Is this regardless of amount of coronary disease or extent of it?
So you can get into some real complexities, but this is like the basics of it. Is that the drugs all work different ways, and you have to take them all to get the maximum benefit. In India, they now have the poly pill. The poly pill is a combination of 3 of these drugs. In India and third world countries, coronary disease is taking over rapidly as the #1 killer because they're not doing the hard work. They're adopting Western diets. And at $10 a month, this poly pill is thought to be the major thing that's going to stem the tide of cardiovascular disease in third world countries. In Canada and the US, the poly pill is not available. It's going to have to undergo years of testing because it's more strict in North America.
What doesn't it have in the polypill?
Most of them don't have the ACE inhibitor part, but they're all a little bit different. But you can imagine if you try to have aspirin plus different doses of beta blocker plus different doses of statin, it gets really complicated because you have to have multiple pills. Okay? So you guys understand the need for taking pills. Now, what pills should a person not take?
NSAIDs?
NSAIDs? What do NSAIDs do? You guys know what an NSAID is? It's like anti-inflammatories like Motrin and stuff like that. How bad are they? So NSAIDs and COX-2 inhibitors, like Celebrex. How many of your patients are on these drugs? Yeah, so in studies of people with heart failure, 40% of people take NSAIDs because they all have aches and pains. But these drugs cause salt and water retention.
They increase cardiovascular mortality as well.
Well, okay, so these increase blood pressure by 3 to 4 millimeters. If you have CHF, because they cause salt and water retention, there's a 40% increase in hospital admissions for heart failure. And these actually make your blood stickier, and it increases heart attacks. So for every 100 people who have had a heart attack, taking COX-2 or NSAID, there's 8 extra deaths or heart attacks in a year.
That's for anybody who's taking NSAIDs, or
If
blood
you
pressure is
have-
going to go up to from 3 to 4?
Yeah, that's the average. Okay? But for every 100 patients who've already had a heart attack, you get 8 extra deaths or heart attacks. These are dangerous drugs. And again, if you have contact with the patients and you know they're on this stuff, you should really try to tell them that this is dangerous. Okay? Do vitamins work? Do they prevent heart disease? Yes or no?
No.
So there's a 13-year trial of 10,000 US physicians given a multivitamin. And so over a 13-year long-term follow-up, multivitamins do not reduce the risk of heart attack or cancer. Okay? Does vitamin E work? Vitamin E was the big hope. At one time, 40% of US cardiologists were taking it. But now with over 100,000 people in vitamin E trials, vitamin E actually increases mortality. So you should not use it. Do fish oils work?
Do what?
Fish oils.
I think if you're like borderline for hypertension, it can help a little bit, like if you're,
So there's
as a preventative sort of.
40,000 patients in fish oil trials now. There's no benefit.
Yeah.
Okay. So no, but these are important because 40 or 50% of your patients will be on natural products.
Even if they're borderline, fish oil does not help.
Fish oil does not help. There's been multiple studies where they put together all the studies and it shows there's no benefit. In fact, fish oil can be of poor quality and it can contain mercury, PCBs, and may be harmful in some cases. So if people are going to use fish oil, tell them to buy the good stuff, not the cheap stuff from China. Okay.
Then why do they say eat fish?
Well, okay, so eating a fish oil capsule and eating a bad diet is not helpful. But if you're eating a healthy diet, which includes fish, natural fish, it might be beneficial. But that's where the science gets murky. But just taking a supplement and eating a bad diet doesn't do anything for you. But in observational studies, people who eat healthy diets live longer. Okay. Does cardiac rehab help you?
Yes.
It's not clear. So if you actually look at just exercise-only programs after a heart attack, and you don't have anything else but exercise, those have not been proven definitively to make you live longer. But if you're in a cardiac rehab program, not only do you get the exercise part, but someone's watching your blood pressure, your cholesterol, making sure you're taking your pills. So that part has been shown to make you live longer. Okay. What else can we talk about? What would you guys like to discuss? Sorry.
How much impact does the amount of NR have?
So if you have an MI, so here's your heart, here's your papillary muscle, okay, and here's your mitral valve. If you have an inferior infarct especially, this muscle is affected. So if you have an inferior infarct, the heart expands, the pap muscle is pulled out, and now the chordae are too short. So this valve is what we call tethered, and this leaflet goes out here, and you get mitral regurgitation. 50% of people that have an MI will have mild mitral regurgitation. 10% of people will have severe mitral regurgitation, and in 2 to 3%, this papillary muscle gets ruptured, and you have torrential mitral regurgitation. It's been shown that even mild mitral regurgitation is associated with worse prognosis. Okay. Anyway, that's just some of the things that happen. Anything else?
How do you choose which diagnostic test to perform when you get unstable angina?
And
You
you
see
mean as an
variability
outpatient?
in some of the cardiologists between, the trestle and the path.
So if you come into the office and with a complaint of chest pain, how did the cardiologist decide if you have angina?
Careful history.
History. And there's 3 components to the history. What are the three components? So chest pain
Yeah,
that
we'll
is
bring that on, what-
brought on by
Yeah, so what we're gonna
exercise.
say.
So if you have a 80% narrowing, okay, at rest, there's enough blood flow, but when you increase the demand of the heart by exercising, you're going to get angina. Okay, so chest pain brought on by exertion or emotional stress. And what takes away the pain? Rest or
Nitro.
nitro. And the third thing is midline pain. So some people, instead of getting their, they get their chest pain here, they might get throat pain, but it's usually in the middle. If people say they have their pain over here, it's probably not angina. If all three of these, we call that typical angina. And actually, this is important for the techs, the stress techs, because I don't know that the stress techs actually know what typical angina is. So that's the three. If you have 2 out of the 3, we call it atypical angina, and it's still possibly cardiac. And 1 out of the 3, we say is non-cardiac chest pain. So we use that to start, and then we'll go from there. So the first test that is recommended is, if we suspect angina, is what? A stress test. Okay. So stress test, you go faster and faster every 3 minutes. You go higher, and we get an idea of how much exercise you can do. People who do more than 8 minutes, they live pretty long. If you do more than 11 minutes on a treadmill test, you will live a long time, because you can exercise. So that integrates how good your heart, your lungs, and your legs are. So one thing is exercise duration, and then we can look at other things, like the more ST segment depression you have, the worse your coronary disease. But I'd ask you, how accurate is a treadmill test? So if you have a narrowing, okay, of 80%, a treadmill test will pick it up only 70% of the time. Okay? Now, we have people that have single vessel disease, we have people that have triple vessel disease. Which one is it more likely to pick up? Triple. You have more ischemia. So it's not bad for picking up triple vessel disease, but for single vessel disease, it's only 50%.
And
So-
so many of them say non-diagnostic because of their abnormal resting basis. So
Right, so before you order a treadmill test, the way you diagnose ischemia on a treadmill is you look at their ST segments, and then at normal ST segment looks like this. Okay, this is what you're looking at, and if it's below the baseline already, and that's what you're looking for, is a shift of 1 millimeter, it's not very accurate. So the other thing is, you have to push yourself hard enough to make sure you've completed your treadmill test. You have to get up to about 85% of your predicted heart rate. So if the patient's on a beta blocker, or then they're probably not going to get the heart rate. The test will be non-diagnostic. If the patient's had a below knee amputation, and you send for a treadmill test, you look pretty stupid, but that happens. But the test is not entirely accurate. So when the cardiologist does this, they really have to take a good history. So if the patient has, this is called Bayesian analysis. So if a 30-year-old woman comes in and has pain in her arm when she knits, what is the likelihood that's coronary disease?
low.
Okay, that's like 5%. Okay.
Yeah.
Now, if you do a treadmill test and it's negative, that means that the chance you've got coronary disease is less than 1%. But what if the treadmill test is positive? Does that mean you've got coronary disease? So the chance you've got coronary disease goes up to 20%. So 4 out of 5 positive treadmill tests in a young woman are going to be false positive. They do not have coronary disease. Do you guys understand that? This is really important to the way a cardiologist thinks. What if you're an 80-year-old diabetic man who has chest pain when he walks up the hill reliably? What's the likelihood he's got coronary disease?
very high.
It's like 95%. If you have a positive treadmill, then you're up to 99% like a coronary disease. But what's the likelihood you've got coronary disease if you have a negative treadmill test? It's still 80%. So just because someone's had a negative treadmill test does not mean they don't have coronary disease. So the stress test, actually, I don't want to say this to the text, it's actually not good enough as to that it should be used as a screening test, but we do. Why do we do a treadmill test? Non-invasive, no radiation, cheap. Okay? But not 100% accurate. So what if we're not sure? We get a treadmill test and it's non-diagnostic or something. What do we do next? Okay, so you can do a MIBI. And what's a MIBI? So here is your heart. Here's the coronary arteries, and here's two pieces of muscle. And what you do is you inject radiation, and you take a picture with a camera on the outside. And at rest, there's radiation that goes into both pieces of the heart muscle. You take a picture, it looks white. So that looks normal. Okay? Then what you do is you get the guy to exercise. These arteries dilate, and then you do another injection of the radiation. And now there's 3 times as much radiation because the coronary blood flow has tripled. Okay? When you look at it again, it's white. So that's called a normal test. Now you have another patient who's got an 80% narrowing. What will you see when you're doing this at rest?
You'll see less of the macular radiation.
Unbalanced. It'll be unbalanced.
You will actually look the same. So at rest, most people that have 80% narrowing don't have chest pain. So you have extra blood flow, and that's enough so that it looks normal. But when you exercise the guy, what will happen? You do another injection. This artery dilates, so there's 3 times as much radiation on this one compared to that one. When we take the picture again, this part looks dark. So it was white at rest, dark with exercise. So that's a reversible defect, and that means there's ischemia here. Does that make sense? Okay. Now, what's the problem with the nuclear test? You guys should all know this.
Expensive.
It's expensive. A regular treadmill test is about $150. A nuclear test is about $350. There's lots of radiation. Right now, there's about 15 millisieverts of radiation, and your background is about 2 millisieverts. So it's about 7 years worth of radiation. So it's a lot of radiation. And we don't worry in people who are old because cancers take 25 years to develop. So if you're 80 years old and you're doing a MIBI scan, who cares? But if you're a 40-year-old woman, you better be careful about how much nuclear radiation you're giving. 2% of all cancers in North America are actually due to too much medical radiation. So people are actually watching that very carefully. But the problem with this is if you have an 80% narrowing here. So yeah, at rest, they have the same amount of radiation. When you exercise them and do another injection, what happens?
It's the same.
It looks the same. So a MIBI test can miss balanced ischemia. This is its weakness. And we, the cardiologists, call nuclear medicine unclear medicine. Because we all have many cases where the patient, the MIBI scan looks normal, and you end up cathing the patient because you're convinced they've got multivessel coronary disease. Okay? Now, stress echo is another test we can do. So we said that regular treadmill testing, the accuracy is about 70%. With nuclear, it's about 85%. And the other test you can do is an echo. So what happens is, here's the heart. Here's an 80% narrowing here. What will I see in this wall at rest? it will pump normally. Again, most people that have an 80% don't have chest pain. They're not ischemic. So this would be normal. When I give them dobutamine or get them to exercise, the heart rate goes up, the demand of the heart goes up, and now this wall becomes ischemic, so it stops moving. So if it was normal at rest, it stops moving, that tells you you've got ischemia. How much radiation is involved? 0. How accurate is this test? It's 85%. So this is as good as MIBI, and there's no radiation. How long does it take to do this test, Jane? About an hour. How long does it take to do a nuclear test? It's about 5 hours. Or if you're overweight, they bring the patient back the second day. So, this test, the stress echo, is a very good way of going. But right now we have a shortage of techs, and this takes some time. So we don't push this in our own center, but it is a very good test. And what's the latest kid on the block? CT. So CT, we talked about millisieverts. CT now is down to 1 millisievert, which is 15 times less radiation than a nuclear test. So I don't even think about the radiation dose anymore. And it's very good. You just inject a dye down the veins, and you get really good pictures of the heart. Now, here's the artery. And what a CT scan will tell you is if there's a 25 to 50, 75 or greater narrowing. And so it can't tell you if it's 10% or 70%. You get ranges. And that is because the corneal artery is usually about 3 millimeters in size, and each pixel, each box that you get, is 0.75 by 0.75. So you can only fit 4 boxes across the normal coronary artery. So you get ranges, 0 to 25, 25 to 50, 50 to 75, 50 to 75. So this test is about 95% accurate. So it's really good. You can't do this though in people who have irregular heartbeats and if they have bad kidney function, because you have to give contrast. But this is probably going to take over from nuclear scanning.
How much does that cost?
This one is actually about $200, so it's cheap. Tests are way more expensive in the States, and so a nuclear test in the States is about $1,500, and a stress echo in the States is about $600. And people are trying to control cost. If the patient has coronary disease, they've had a stent, should they have a treadmill test every year? With all of them. What do the stress test people say?
Yes.
Okay, you're wrong. So they've tested this. They've done nuclear testing, and they've done exercise testing every year in patients and compared to just follow them for symptoms. And you can pick up things a little bit earlier if you do the testing, but it has not been shown to alter mortality. So right now it's a class 3 recommendation, which means you should not do annual treadmill testing in people with known coronary disease. It's contraindicated. Yes.
Can I ask a question? So when we're talking about chronic plaques and the 80% plaques that you were showing, there's a study that Dave was doing where they're doing like the non-culprit lesions. So you're essentially stenting chronic plaque, I guess. What are the benefits of
This is the
that?
most.
Because they always do like the culprit lesion, and sometimes you see 60s and 70s, and they don't go after those ones. So what is the, I guess, I know he was doing this study, so I just kind of wondered.
Okay. I have this patient. This patient has angina on walking 5 blocks. It's reliable angina. And I cath him. He's got an 80% narrowing. At the time he goes to the cath lab. I randomize him into a study. This is called Courage. 3,000 patients with stable angina In half the group, I open up the artery, and in half the group, I leave the 80% narrowing. And I treat them with aggressive medication. Okay? This is stable angina, never had a heart attack, never been hospitalized. What is the risk of death? And the risk of heart attack, and the risk of angina. If Dave Wood stent this one, will the patient live longer? Hands up. Hands up say it doesn't make a difference.
We need to know the extent of the coronary artery disease.
Sorry?
Don't we need to know the extent of the coronary artery disease?
80%. 80% narrow.
But it's chronic and it's sensitive because of the person.
I think this is very, very interesting. The cardiologists always think about this kind of stuff when they're making their decisions. And I think the nurses should think about this stuff too. Anyway, this study, which is highly influential, called the COURAGE study, no difference in death to opening up the artery, no difference in heart attack in opening up the artery. And angina, would you improve angina by opening up the artery? Yes. But if you were treated just medically, you had an 80% narrowing, 50% of people had no angina on medical therapy, and about 60% of people had no angina after a stent. So the difference was only about 10%. It was statistically significant, but not a huge difference.
How long was that for the death and the MI?
5 years.
So then why are we doing the study then when we're going in and stenting non-complications?
That's different.
In that?
That's different.
Oh.
But
Wow.
I think this stuff is very interesting. That in a stable patient, the risk of death in MI is so low that opening it with a stent doesn't do anything. And why? I explained this to you already. 75% of heart attacks are caused by the 20% narrowness that we're not treating. So you still have to treat them medically aggressively with the medicines we talked about. But stenting itself does not make you live longer. Now, a heart attack is different. Our heart attack, you've got, we divide these patients into STEMI and non-STEMI. What's the difference?
STEMI's gone through the whole heart.
Yeah, so now, if this plaque breaks open and you get a clot, and it doesn't block off entirely, that's a non-STEMI. So there's still blood flow going down, so you put them on relatively weak blood thinners like heparin and aspirin and Plavix, just to maintain the blood flow. But if it's a STEMI, which means that you get SC elevation, means the artery is completely occluded, and you must do something urgently to open up the artery. So you give them a thrombolytic, strong clot buster, or you put a stent in. And so that has been shown to make you live longer if you have an unstable plaque. But what David's study is, you have, here's your arteries. Okay. So this artery is blocked, so that is being damaged. This heart muscle here is being damaged. Okay, so you have to open it to minimize the damage. And there's something called the golden hour. If you come in and you get your artery opened up in the first hour, your risk of death is reduced by 50%. And it falls off, and by about 12 hours, there's no longer any benefit to opening up the artery. Okay? So we know you must treat the infarct-related artery. But the question is, if you have a 70% narrowing in this artery, should you fix that? And no one in the world knows if you should fix that. Because in a few months' time, this patient has gone from acute coronary syndrome to more stable coronary disease. And this, we just told you, the COURAGE study showed no benefit.
Mm-hmm.
So the other thing we know is if you take pictures at the time of a heart attack, the heart is inflamed, the arteries are inflamed. So this one that looks like a 70% narrowing, if if you take pictures 2 weeks later, often will look like a 50% error. So no one knows at this point whether you should fix that one or not. Okay. Any further questions? Yes?
I just have a question about, like, if the RV is involved in an infarct, is the prognosis a lot worse, and can it recover the same as a left ventricle, or does it have less collateral?
Okay. So here's the heart. Okay. So the right coronary artery supplies the right ventricle and the inferior wall. If you block off here, then you can infarct the right ventricle and the inferior wall. If you have right ventricular involvement, your mortality is 3 times higher. So it's bad. But the RV often can improve. It's maybe a little bit too complex to talk about why it improves so much, but it's associated with a bad prognosis if you have RV involvement. Okay. When can people have sex after their heart attack?
When they can climb a flight of stairs without
Yeah, as soon as they can go a flight of stairs, they can have sex. And if they have chest pain, they have angina because we can't fix everything, then you tell them to have sex. But don't smoke before sex, don't eat a heavy meal, because the blood goes to the stomach, and get the partner to do all the work. Okay? And under no circumstances have sex with triplets.
Right.
Okay? When can people drive after their heart
Watch out
attack?
for the Viagra.
Sorry?
Watch out for the Viagra.
Okay, can you use Viagra if you have coronary disease?
Yes, but you can't use nitrate.
Yes, you can use it, but you can't use nitroglycerin because at the same time, because it will cause a dangerously low blood pressure. So with the Viagra lasts for 24 hours, so no nitrates for 24 hours. Cialis, they call it the weekender because it lasts longer. So you can't use nitroglycerin for 72 hours. But in stable patients that don't need nitro, you can use Viagra. Okay. When can people drive after the heart attack?
A month.
So if they've had a big heart attack, if they have a STEMI, then it's automatically you can't drive for a month. If you have a non-STEMI, so a tiny troponin elevation, and you get fixed immediately, that same admission, you can start driving within 48 hours. If you have a non-STEMI, a tiny infarct, but you have to come down, you didn't get fixed during that hospital admission, you have to wait 7 days after the angioplasty is done. But in all circumstances, usually by a month after their heart attack, they can drive. It's different for if you're a commercial driver. Okay, but I think I wanted just to cover some of the basics of medications. The other thing is, I will tell you, there's a study called Premier. So Premier was a study, and they looked at what happened. IER, I guess. Okay. Anyway, this was a study of about 1,100 patients with an MI. And they looked at their medications at 1 month. And they looked at aspirin and beta blockers and statins. So they said those are the 3 drugs they looked at. And they looked and see, did you fill your prescription at 1 month? And then they looked at mortality at 1 year. Okay. So about 20% people stopped all 3 drugs at 1 month. Mortality, if you stopped all 3 drugs, was 11.5%. Those that took all 3 drugs, which are about 70% of the population, had a mortality of 3%. So, this is a real life study showing what happens if you don't take the medicines.
You find that when you see patients you follow up?
That
Do
they
you
stop.
find that?
Yeah, and then I always go through this explanation of why they have to, and they say, oh, I didn't realize that. But I think that the opportunity, I know that it's challenging for you guys because the amount of time they spend in hospital is relatively short, but still, I think we could be doing a better job with patient education. Okay.
Did they look at why people stop?
So actually, it's been shown that if you're married, you're more likely to take your medication, and if you're more highly educated, you're more likely to take your medicine. And of course, one of the things that is a problem is cost. So most heart medications are about $1 each. So if you're on 4 different drugs, that's $4 a day, and some people can't afford that. Elaine was, in the CCU, was going to start a project where she was going to make sure that they get pharmacare coverage before they leave hospital. I think that's something that was going to be very good, but it's tough when you don't have enough money.
And then patient education, how much do you feel that impacts?
So, I brought this up a number of times, but there's a study, a group called Cochrane, and they actually said how much benefit is there to patient education. And in most cases, patient education does not improve outcomes. There's been so many studies done, and it may have a tiny effect on improving blood pressure. It does not improve diabetes, does not improve stroke care. So the question is, how much time, money, and effort should you put into this? I think if you're there, what you should be delivering is a consistent message. And I think that would be helpful. We used to have this script. When I was CCU director a number of years ago, we had a 3-page document that the CCU nurses and CP10 nurses could have, and they would read it, and then they could tell people something consistent. How much alcohol should people drink?
1 per day for women and 2 per day for men.
So, okay, so men get 14 drinks per week, and women get 10 drinks per week,
Okay.
because they're smaller and they metabolize alcohol more slowly. So that's 1 standard drink is equal to 5 ounces of wine, 12 ounces of beer, or 1.5 ounces of hard liquor. So I think those kind of things where if you guys are able to show consistency would be good. So how many of you actually would think a handout telling the patient some of this stuff would be useful? Well, if you do, then Kimmy can prepare.